Hello everyone. Again, good morning, good afternoon, or good evening from wherever you are watching this second edition of the International Aesthetic Masters. Here we are starting the third day of great conferences. This time we start in Europe, and I'm proud to present one of the masters in French dentistry, Dr. Jean-Pierre Attal. Jean-Pierre got his dental degree in 1988 at the University of Paris-Descartes and got a PhD title in 1995 from the same university. Finally, in 2008, he received his accreditation to supervise research at Paris-Descartes. Dr. Attal has been linked with research for many years of his professional activity and has been director of a research center and of a master in biomaterials engineering at Paris-Descartes. He is the president of the French Society of Biomaterials and redactor-in-chief of the Biomaterials Clinics Journal. Since 1997, Dr. Jean-Pierre Attal is a member of the faculty teaching undergraduate and graduate students on the subject of dental materials. Jean-Pierre will open this third day with a lecture on aesthetic, biomechanical and functional goals of restorative dentistry. Is it possible to reach them without any drilling? We start this third day with oral minimal invasive rehabilitation, and I hope you learn a lot. See you in a couple of hours.
Hello, first of all, I would like to thank the organizer for inviting me in such prestigious congress, the International Aesthetic Masters. The subject of my conference is the following. Is it possible to reach the objectives of restorative dentistry without any drilling? I've chosen this subject because no longer drilling the teeth brought me more job satisfaction with the medical aspect of the profession, fewer problems difficult to manage, and simplification of most of the treatment plans, and less stress because when you have a problem with a procedure, it is very easy to overcome as you almost didn't drill. Let me introduce myself. I'm a dental materials teacher in Paris-Descartes University. I teach dental materials and, of course, dental manufacturing with subtractive and additive manufacturing. I am also director of Dental Materials Lab, which main objective is to design and manufacturing of a 3D printed biomimetic restoration. That's why I'm very proud to belong to the international group of bioemulation. I also have a consultation of bleaching in Paris for young people with pathology, adult and old people. You will see that I love very much bleaching. I'm redactor-in-chief of a new journal. It's a clinical dental materials journal, BMC, at the interface between scientific approach and clinical approach. I chair the French Society of Dental Materials. And now I would like to present you my main mentor is Professor Michel Degrange, who died 7 years ago. He was a very well-known specialist in dental materials and dental adhesion. He has created with Jean-François Roulet the International Journal of Adhesive Dentistry. I have other mentor, Francesca Vailati, mostly a friend, and thanks to her, she allowed me to become a serial tool skiller. And of course, the master, Pascal Magne, and his own master, who's there. At least, my friend, Gilles Tirlet, I would like to associate with this presentation because we have done a lot of work together on this subject.
Let's see now the plan of the presentation. The first point I'd like to describe is the frequently necessity of orthodontics for adults treatment. Let's take an example with this patient with anterior erosion of maxillary incisors due to gastroesophageal reflux, no anterior prosthetic space, with no erosion on posteriors. In this case, we don't need to make onlays to increase the vertical dimension. You have just to ask the orthodontics if it's possible to provide anterior space with an orthodontic treatment, and the treatment is becoming almost simple. Here we can see dotted the loss of substance of the incisors, but the compensatory aggression does not allow to restore them easily, so we need some supplementary space. After orthodontic treatment, after 1.5 years, a prosthetic space is available to restore the anterior maxillary teeth. Here are a few steps of the treatment with the setup, with the orthodontic appliance, the 4 palatal laminate veneers, and some steps of the bonding procedure and the composite resin on the labial surface. As we have anterior space, it is possible to get nice morphology of central incisor, as you can see here, without any drilling. After bonding of the palatal composite veneers, we can have these views, and here we can see the nice morphology of central incisor. To summarize, before, after orthodontic treatment, you have space without any drilling, and after palatal veneers. Of course, you can see that there was 2 implants in the posterior area. Before and after at the face level, of course, we achieved a bleaching. And in conclusion, we had no drilling at all, just orthodontic steps for palatal veneer, bleaching, and composite resin. This case illustrates well our philosophy, just orthodontics step and bonding. Another typical case of erosion with a patient with gastroesophageal syndrome, which explains the erosion of maxillary incisors. And with an important dehydration, he ran the marathon, which explains the loss of substance of inferior incisors due to the lack of saliva. Slight loss of substance in posterior. The situation is not so easy because no anterior space to restore due to the compensative aggression, but it can be solved once more time simply with the help of orthodontics. After 1.5 years, we have enough space to restore easily with palatal veneers and with composite or with ceramics in labial seat. At the beginning, after orthodontic treatment and after the mock-up, I am at the stage of the mock-up for this treatment. For the moment, no drilling at all. Before, after orthodontic treatment, and after the mock-up. To conclude on this chapter related to orthodontics, I'd like to say that I believe very much in lingual appliance because it is far much easier for an adult than labial appliance. The system I prefer is WIN from the very well-known Dirk Wischmein. It is an invisible system, suitable for all ages, with extremely flat bracket adapted to the tooth, and the arc wires are bent by computer assisting bending robot, so it's very precise technique. I'm very impressed of what is possible with this very precise technique. Christine Muller in Paris knows very well this system, and she treats all my cases. This system allows get results, as you can see on this short video. We begin with a very difficult case, and with this video we can see the possibilities of this system, this very precise system. Another example with this system, we can see unbelievable periodontal and teeth harmonization before and after. When I talk about ortho, I face aesthetic objections from the practitioners. But with new lingual therapy, patients can even get married. There is no visible brackets. Patients more readily accept orthodontic treatment when brackets are invisible. Here is a mouth of this very beautiful married woman with orthodontics appliance. To conclude, I would say as Kuljic in this paper that we should merge orthodontics and restorative dentistry to obtain without any drilling predictable aesthetic and functional results in dentistry. You have to remember, orthodontics is one of the best treatments we have, safe and effective, without any drilling to achieve all our objectives of restorative dentistry. The second part of my presentation deals with bleaching. In my opinion, bleaching is not enough used, and we can also use bleaching with orthodontics. We have many indications of bleaching. First, because the demand of bleaching is high. In this study, we have almost 40% of the patients unsatisfied with their tooth appearance. The first cause of insatisfaction for 90% of the patient is not enough white. The second cause is teeth misalignment. So, a dentist who doesn't use bleaching and who doesn't work with an orthodontist cannot answer either to the first nor to the second demand of today's patients. It's like a cardiologist who decides not to treat coronary heart disease or high blood pressure. We can bleach young adolescent with fluorosis lesion. Just see the eyes of the patient, which demonstrates the great modification had on his mind. It's a very frequent indication, as in this case, before and after. We use always the same molecule. It's carbamide peroxide at 10% during 3 to 12 weeks. Here in this case, we can see the initial situation after 2 weeks and after 4 weeks. The patient is very pleased. We can bleach also old patient. Here, a 75 years old patient. They are very happy after bleaching. Even some dentist thinks that they are too old. We can also bleach this population. When you associate bleaching and ortho, it is a very efficient association. Many people are interested in this nice association. In this publication, we have guidelines and answers to questions about bleaching associated with orthodontic treatment. Here in this case, the patient with malocclusion and tetracycline discoloration. Orthodontic treatment and bleaching before and after. We have a very nice results after 3 months of bleaching. What's more, no drilling at all. Of course, for tetracycline discoloration, we need at least 3 months or sometimes 6 months bleaching. Bleaching can be associated well with composite resin, of course. It allows, without any drilling, to render service to this patient. For example, 3 months before wedding, after bleaching and after composite resin, the result is very nice, and you have to ask her a picture of her wedding before and after, and it is once more time without any drilling. Few points I wanted to highlight on bleaching. First, vital bleaching using 10% carbamide peroxide is safe and effective, with many scientific proofs like this clinical study after 70 years follow-up. Here a picture of the inventor of the technique, it's Van Hywood. The second point I wanted to highlight is the fact that many GP are afraid about sensitivity, but it is possible to avoid them during a bleaching treatment. The sensitivity depends on the duration of contact between the carbamide peroxide and the tooth, and we know, as in this study, that 1 hour is sufficient to have a nice result. So, the objective is to find out the personal time of application for each patient. We can advise them like this. Wear the trays 1 hour the first night, then if no sensitivity appears, proceed to 2 hours on the second evening. Gradually increase to 3 hours in the evening or all the night if you support them. And this for 2 or to 6 weeks depending on the prescription of your dentist. With this procedure, you will never or almost never have patients with sensitivity. The third point I wanted to highlight is that there are many false contraindications forbidden for smokers. It's false. Patients who don't want to have a white diet, it's false. Patients suffering from dental erosion, it's false. Patients with caries susceptibility, it's false. I advise you to go to my blog to see the scientific references to demonstrate all these false contraindications. The fourth thing I wanted to highlight is that the real mechanism of bleaching is not so well known. We all know the mechanism of oxidation of the chromophores. It is a chemical part of the bleaching mechanism with the oxidation of this molecule to this molecule. But there is a physical part of bleaching. Indeed, in this very interesting article, the authors succeeded to evaluate the separate contribution of enamel and dentin to tooth color change in tooth bleaching. We can note that the variation of lightness with bleaching is poorly due to dentin in green and mainly due to enamel in red. The overall increase of lightness of the tooth is in blue, quite the increase of lightness of enamel. We have the same result for B value. B value is a yellow parameter. And the evolution of translucency parameter of enamel in purple shows that during bleaching there is an opacification of enamel. It is the main component of the modification of optical properties of tooth. So, there are two components of bleaching mechanism. First, chemical component with oxidation of the stain molecules. We need long duration application to obtain the result. And there is physical component with enamel opacification and some surface modification of enamel. And this physical component is short duration. That explains many things. First, while the color of natural tooth is the color of the dentin, it's a very well-known result, the color of bleached tooth is the color of enamel. As we have published a very nice paper in BMC, Dental Materials Clinical Journal, in French. That explains why it is so difficult to bleach the cervical zone and the root. We can understand that now because in the cervical area we have only 300 micrometers of enamel, so the opacification can't be efficient. As you can see at the coronal level, we can see a very nice opacification of enamel here. We need to go on with a chemical mechanism to decrease the yellow color of the cervical zone, and we will have a slight decrease of the opacification of enamel with time. So after 1 month, at least that explains why it is more difficult to establish the color after bleaching. To conclude, we can say that bleaching is one of the best treatments we have, safe and effective without any drilling, and we can have all our objectives. In many cases, of course, we speak mainly of aesthetic objective of restorative dentistry.
Third part of this presentation, adhesive dentistry. First of all, I would like to say that I like very much to repair whenever possible. Indeed, GP are used to replace defective restoration, but it is possible to repair it. In this practice-based study recently published, the authors showed that repair is a minimally procedure which can increase the survival of the original filling, reducing the risk for pulp complication and treatment cost. It allows a 50% reduction of annual failure rate. It is the same conclusion from this recent survey, once more time, minimally invasive. Preserving tooth structure and time and money saving are the main characteristic of repair. As an example, it might be a slight repair of the wear degradation of the luting cement of this inlay, for example. Sandblasting, of course, is necessary, etching, and we advise the use of an universal adhesive because it has adhesion potential to different materials. It might be a repair of fracture of feldspathic ceramic with the well-known following steps: slide burr cleaning, etching with fluorhydric acid, silane, universal adhesive, and composite finishing. What's more time, we advise universal adhesive in this case because of its adhesion potential to ceramics. In this case, it's a little bit more complicated with this patient who wants to increase the aesthetic of its bridge.
To replace this bridge might be dangerous. However, we know very well to bond on dentin, to bond on metal, and to bond on ceramic. So, the clinical process consists in sandblasting, isolation, phosphoric acid on dentin, courgette on metal, silane, universal adhesive, lacquering, opaque composite, aesthetic composite finishing and polishing. The aesthetic result is not perfect because I made a mistake on the shade, but the patient is very happy and he asked me to the same treatment on another tooth, as you can see here, before and after. I really believe that in the future we will repair more and more restorations instead of replace them. So restoration repair is one of the best treatments we have, safe and effective, without any drilling. Adhesive dentistry allows also some treatment when you face an anterior edentulous. And I like very much resin cantilever bonded bridge in this case. Loic was my first case. 14 years old, at the end of an orthodontic treatment, he had an infected incisor and we had to extract this tooth. With a too large mesiodistal width, I made a cantilever resin bonded bridge. I've learned this geometry from Professor Matthias Kern from Kiel University in Germany, bonded with Panavia F2.0 with the famous MDP monomer able to bond to zirconia. So we have a 2-unit cantilevered fixed partial denture, a single abutment and a single pontic. Here are the results after 11 years and a half. You can see that the results are very nice and the treatment is well easier than implant treatment. It is an unexpected result, but it is now well recognized that less number of retainers is recommended for resin bonded bridges. As it is deeply developed in the new very nice book from Matthias Kern, I advise you to buy it. We can extend this indication with cautiousness in the posterior area. The risk in this case to remove this bridge is very important, and we can do a cantilever bridge. In this case, the patient has a medical implant contraindication, and adhesive dentistry allows to bond on canine with a slight preparation, and probably today I would be less invasive. Few views of the different steps with the resin bonded bridge made in zirconia and bonded with Panavia F2.0 and the follow-up after 4 years and a half. A very nice result. But a surprise, after 5 years we had a debonding with a mixed failure, as you can see on these two pictures, composite left on the retainers and composite here on the tooth. It is not a real problem when you use zirconia because you have not fracture, and most of the time you can rebond it. And here is the result after rebonding. So for me, resin bonding cantilever bridge is one of the best treatment we have, safe and effective for anterior edentulous
with a small amount of drilling.
Now it's time to speak about our fourth chapter, infiltration, a French specialty. The original idea is not a French idea. Gilles and I have only proposed new indication of a product from DMG company, which was initially proposed for infiltration of incipient carious lesions. But as it was described in this article, this product allows also masking of white spot by modifying enamel optic properties. We had with Gilles the idea to extend the indication to fluorosis, MIH, and trauma lesion. First of all, to understand the treatment, you have to understand why a white lesion is white. When enamel is normal, the light beam, enamel is normal here, sound enamel, the light beam passes through the enamel without being deflected. It is reflected when it reaches the dentin, and the enamel is translucent. But when enamel is hypomineralized, here, the light beam is deflected several times because of the differences between refractive index between the enamel and water and proteins present in these porosities. The light beam is reflected and the lesion appears whitish. So, how to transform opaque enamel into translucent enamel? Simply by infiltrating the porosity with a resin, which has a refractive index close to sound enamel, you allow the light beam to be transmitted. No more reflection and no more whitish aspect. It is simply an optical effect. You can more understand the optical phenomenon with this simple video. Let's soak a glass stick in water. Due to the differences between the refractive index, the stick can be seen. But if you soak the stick in a glycerol solution, which refractive index is close to the glass, no more reflection, just transmission. You can't see the stick anymore. It is exactly what we do when we infiltrate hypomineralized enamel with icon. We are going to do exactly the same. We have proposed to DMG company to work on this subject, how to mask all white lesions with their product. So they help us, of course, to invent new procedures with their product icon. What is icon? Icon is a product composed of three components: icon H, chlorhydric acid 15%, icon dry, ethanol, icon infiltrant TEG-DME. And there are three original steps of the treatment. Step 1, chlorhydric acid eliminates the hypermineralized surface to be able to reach the lesion and to be able to infiltrate it. Step 2, drying step to see if we are in the lesion and to eliminate water to allow the resin to penetrate. It's the role of icon dry, ethanol. And step 3, infiltration of the resin. And after this infiltration, the lesion is masked. The product is called icon infiltrant. Here is a plan of the presentation of the technique we developed about infiltration. We begin with the first attempts and the first successes. It was more than 8 years ago. So, a clinical case to begin, initial status showing a simple white spot. The etiology concerns trauma during youth. This patient was suffering from the white spot, but his mother didn't want a dentist to remove sound tissue. We are going to do what we are going to call in a few minutes superficial infiltration. Here's a white lesion at the smile level. And the first step is an etching step with chlorhydric acid. With a gentle pressure in the circular motion, we try to remove the hypermineralized surface, and therefore we can have access to the body of the lesion. But it is not so easy to know if we have access to the lesion. So we need an indicator. After rinsing and drying, alcohol is the indicator. If alcohol masks the lesion, the infiltrant will mask also the lesion. In this case, we needed 2 cycles of erosion and alcohol before infiltration. And now you can see the result after infiltration. The lesion is now nicely masked. At this stage of treatment, we have to say a few words about biocompatibility. Because when you do a superficial infiltration is at the contact of biological tissue, cheek and tongue. So you need to be sure that the resin infiltrant is not toxic. The first concern is the quality of the polymerization. In this paper, we can read that with ICON, there is a good curing efficiency but an important extent of oxygen inhibition. The authors evaluated the oxygen inhibition layer at about 40 micrometers. To eliminate it, you have to cure under glycerol or under any material to prevent oxygen inhibition. So here are the crosses I draw to show the unsaturated monomers at the surface after the first polymerization. You have to apply a layer of glycerol and light cure through it. And the unsaturated monomers will disappear. Same kind of result in this paper. Biocompatibility of ICON infiltrant is very good if light curing is efficient. The evaluation was about cell viability in this paper. Let's now come back to the first case. After infiltration and a good polymerization, the white lesion has disappeared without any invasive treatment, without any drilling. Before and after at the smile level, before and after the treatment at the face level, the patient is very pleased. At the end of this simple case, we can begin to draw a part of what we are going to call the algorithm of treatment. The GP has just to follow this to know what has chlorhydric acid, and you apply ethanol. If there is a maskage with ethanol, you can infiltrate, and after you have just to polish. If there is not a maskage with ethanol, and if you did only one application of chlorhydric acid, you can do it once more time. And in this case, after 2 applications of chlorhydric acid and ethanol, we had a maskage with ethanol, so we decided to infiltrate. And of course, because we are at the very superficial level, there is no loss of substance, there is no concavity on the enamel surface, so you have just to polish and it is the end of treatment. But these nice first successes were followed with first failures. Although we had some good results in some cases, in others we had some disappointed results because the whitish aspect was still persistent. In this case, for example, we have the lateral incisor with still a whitish aspect. There is only a slight maskage. It was very often the case in case of MIH or in case of trauma and deep fluorosis. In some other cases, we had what we have called the edge effect. The maskage was good at the center of the lesion, but not at all at the periphery of the lesion with a whitish aspect. Of course, we understood that there was a maskage, and it was good when the resin had been infiltrated, and we saw white lines where the resin hadn't been infiltrated. The same kind of case
with a maskage in the center of the lesion and a whitish aspect, a white line at the periphery. Another example of the edge effect, in this case, we have also a spot in the center of the lesion. In fact, we did not really understand what was going on. As we wanted to understand the failures, we decided to create a research team on this subject, mainly on the anatomo-histo and physiological aspects. We have published several papers on this subject and we have found out many informations. In case of fluorosis, the lesion takes place at the third external of enamel. In case of MIH, at the third internal of enamel. So we understood why the superficial infiltration didn't work on MIH. The lesion is too deep and infiltration of sound enamel at the surface leads to almost no optical change. In case of trauma and carie, the lesion takes place also at the third external of enamel. So with this new information, we have proposed a new kind of infiltration. Let's come now with this new idea which has totally changed this treatment of infiltration. It is a French idea, the infiltration in depth. When the lesion is deep, you have to reach the lesion to infiltrate it. And after, you have to apply a composite resin to compensate the loss of substance made by the drilling or sandblasting. You accept a slight loss of substance, but it allows to mask totally the lesion. Now the lesion can be infiltrated because we have reached the lesion here with sandblasting and drilling, for example. The key moment of our work on infiltration, it is the day we had the idea to infiltrate in depth. It is a very simple idea, but nobody has never thought about that before. And a composite resin to compensate the loss of substance. Actually, there is two techniques of infiltration. Superficial, just erosion, drying, and infiltration, no drilling at all, no sandblasting, no composite resin. But deep infiltration with drilling or sandblasting to reach a lesion, and after erosion, drying, infiltration, and composite resin. We use superficial infiltration mainly for slight trauma, fluorosis, and carious lesion, and deep infiltration for MIH or severe trauma, carie, or severe fluorosis lesion. The main difficulty of the treatment is to know when to infiltrate. You have one indicator, alcohol. After erosion, rinsing, and drying, does alcohol modify optical properties of the lesion? If yes, as in this case, just before alcohol, just after alcohol, the lesion is totally modified from an optical point of view, so infiltration is possible. If it's not the case, you have to apply chlorhydric acid once more time until modification with alcohol, or you have to sandblast and drill just before erosion until modification with alcohol. The rule of the treatment is never infiltrate if there is no modification with alcohol after erosion. Let's take an example to better understand. On the left, after drilling, a little, maybe less than 100 micrometers, after erosion with chlorhydric acid, rinsing and drying. It is the case here. Let's have the look on the optical modification of the lesion with alcohol. On the right, you see that alcohol penetrates well in the center of the lesion, but there are
areas without modification, as you can see them here, without modification. You have to drill or sandblast exactly on these specific areas and apply once more time chlorhydric acid. Try to remind the zone. It's not so easy because alcohol evaporates quickly. So, for example, you can take a picture, but please do not use a pencil because ink will penetrate. The second step after drilling, erosion, rinsing and drying on the left, you can see the application of alcohol on the right. You see it is far better, but there are still some areas without optical modification. Here, 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 and a little here, and a slight white line here. So you have once more time to drill or to sandblast this specific zone. We need another cycle of drilling, erosion, rinsing, drying on the specific area, and after the application of alcohol, you can see the result. No more area without modification of optical properties. Alcohol penetrates very well everywhere, so the infiltrant will penetrate well also. So you have to keep in mind that if alcohol penetrates well, resin infiltrant will penetrate well. We can now understand other part of the algorithm. After application of ethanol, if the maskage is sufficient, you can infiltrate, you know already this part of the algorithm. But if after 2 cycles of chlorhydric acid there is no modification of optical properties with ethanol, you have to sandblast and go once more time for a cycle with chlorhydric acid. But remember, you sandblast or you drill specifically on the zones without modification of optical properties. You follow as many times as necessary these cycles until you have a total optical modification with alcohol and you can infiltrate TAG-DMA. After light curing of the infiltrate, the resin will be used as an adhesive support. It is for this reason that glycerin should not be used. Several studies have shown that bonding between the resin infiltrate and composite is of very good quality. So please never use glycerol in case of infiltration in depth. To summarize, compared with superficial infiltration, deep infiltration produces a slightly higher degree of mutilation, but always remain within the enamel. Since the natural optical characteristics of the tooth are restored, the success of treatment depends simply on the quality of the polishing of the thin layer of composite. Let's go now with the role of bleaching. It's a very important role. Let's begin with few examples. In this case, the diagnosis of fluorosis is not obvious. She is 15 years old with Let's go now with the role of bleaching. It is a very important role. Let's begin with few examples. Here, a 15-year-old girl with severe MIH. What is the treatment? First of all, the diagnosis is not so obvious because maybe we can say that it's fluorosis. Nevertheless, if we bleach first, the brown part will almost disappear and the white part of the teeth will be less visible due to the decrease of the contrast with the yellow part of the teeth. Before bleaching and after bleaching, we still see the white spot, but the patient didn't want the treatment of white spot. She is very happy. She can smile. Another similar case, after bleaching, we still see the white spot, but the patient didn't want the treatment of white spot. At the endobuccal view, before bleaching and after bleaching, we still see the lesion. The patient is very happy. Another case with an 18-year-old girl with two small white lesions. What is the treatment? First treatment is bleaching. Before bleaching, after bleaching, we still see the white spot, a very small white spot here in the lateral incisor, and the patient is very happy and she didn't want the treatment of white spot. If we see the two white spot, the two first white spot, it was the reasons of the consultation. We still see them, but for the patient, no need of further treatment. Another case, before bleaching and after bleaching, we still see the white spot, but the patient didn't want the treatment of white spot. So now we can understand another part of the algorithm. First, you try to bleach, and if there is a sufficient maskage, yes, it is the end of treatment. But sometimes things are different. In this case, for example, the patient after bleaching wants to better mask the lesion because for her it's not sufficient. So in the case of the patient is not enough satisfied, or in the case of it is not possible to bleach, we have to do erosion and infiltration. You have to use icon to mask the lesion. Now it is possible to make the synthesis of the algorithm. What is an algorithm? An algorithm is a finite and unambiguous sequence of operations or instructions to solve a problem. GP like very much algorithms because they help them for the sequence of the different stages of a therapeutic. Here is the algorithm of treatment. We know already some parts of this algorithm. Bleaching or not bleaching, sufficient maskage or not sufficient maskage, maskage with ethanol and infiltration, and if no maskage with ethanol after 2 applications of chlorhydric acid, infiltration in depth, preparation, sandblasting, drilling, and we are going now to study the other parts. First of all, at the very beginning of the treatment, you have to select shade of the composite because you don't know if you will have a superficial infiltration or an infiltration in depth. And if you forget that step, it would be too late after because of the dehydration of the teeth. And after having selected shade, you can begin with the cycles. Let's see how this algorithm works for deep infiltration. You know already this part of the algorithm. The first difference between superficial infiltration and infiltration in depth is sandblasting and drilling. And you have a second difference because after infiltration, there is a concavity depending on the sandblasting and the drilling. To compensate the loss of substance, you have to fill the concavity with a composite. And now we face three main possible situations according to the aspect of the infiltrated lesion. Let's begin with a case where the lesion is white and translucent after infiltration. You have to compensate the loss of substance with a composite, and in this case, it's an easy case because you have to use an enamel composite. As we can see in this case, from Dr. Maud Denis and Dr. Gilles Tirlet, the infiltrated lesion has a good lightness. And if you use a composite enamel, you have a very good result because you have nothing to mask. Very nice optical properties. Before, after. Before, after. Very nice result. The second possible situation is when the infiltrating lesion is slide colored, and in this case you have to use a composite body. It's easier to obtain good results. Here you can see a 15 years old girl with MIH with this lesion on the mandibular incisor. Her mother doesn't want any bleaching. In this case of MIH, no modification of optical properties after chlorhydric acid application and alcohol. You need to drill to sandblast to get access to the lesion. And you begin the cycles as you know, chlorhydric acid, alcohol, drilling selectively. Once more time, chlorhydric acid, rinsing, drying. On the left before infiltration, on the right after infiltration. And you can see that after infiltration the lesion is slightly colored, and a body composite, intermediate translucency between dentin and enamel would fit perfectly. The application of the composite and polishing. You can see the results at the smile level, very good result, and the results at the face level. The patient is very happy. Let's have a look to the algorithm. You can follow the green arrows, no bleaching in this case, and after the cycles you know now, we have a concavity with a slight colored lesion infiltrated, so we use a composite body. And it's the end of treatment. Another clinical case, we have a clearly deep hypomineralization. It's a situation of trauma. And after many cycles, and in this case some blasting very early because it was obvious that the lesion was deep, chlorhydric acid, drying, rinsing, a first test with alcohol, and after few trying, we decided to infiltrate before infiltration and after infiltration. In this case, the lesion infiltrated is slightly colored, and a body composite would fit perfectly also. A body composite, in this case, is Asteria from Tokuyama, polishing, And final results before and after. We can see the results at 1 year follow-up and at 5 years follow-up. It's a picture from the orthodontist. Let's have a look to the algorithm. You can follow the green arrows, the red one because it's a specific step of sandblasting or drilling with infiltration in depth. Another case, a 10 years old with fluorosis lesion, a nice girl. After infiltration, the lesion is slightly colored, so body composite, a very thin layer, would fit perfectly. At the end of the first session, at the end of the second session, and if you have a look to the algorithm, you can follow the arrows, and it's very easy for the practitioner to follow the arrows and to know all the steps of the treatment. The third situation is when the lesion is colored. But before studying this situation, few words about the treatment of brown spot. Icon is only efficient on white spot. So, in case of brown spot, we have to bleach first. But if bleaching is not sufficient or not possible, several cycles of sodium hypochlorite would do the job. During the cycles of erosion, we propose to apply a 5% solution of sodium hypochlorite. It is an old knowledge, we can see in this article, that the solution can remove colored molecules. It is not totally efficient, but it helps to decrease the coloration. And after these cycles, generally, the infiltrated lesion is still colored. In this case, we have to apply a very thin layer of an opaque composite and a thin layer of a body composite. Opaque composite, like Essentia from GC company like Dentine, and body composite like Asteria from Tokuyama company. Do not hesitate to make some horizontal lines to avoid light transmission and to mask the brown spot. At least the last part of the algorithm, if you become an expert, you know really how to recognize the depth of the lesion. And you can begin directly with a slight sandblasting or drilling about 100 micrometers, and you will gain time. So in conclusion, we can say that with the application of this algorithm, it is possible for GPs to treat all the lesions, whatever their etiology. I would like to finish this description of the technique with a new indicator to know if you are or not in the lesion. It's the use of scalpel. Scalpel allows detection of hypomineralized lesion because the scalpel has no action on sound enamel, and if you have a sandy action, you do not need to drill anymore, so you gain many time.
So, I just finished my presentation and I hope that you have appreciated it. And to conclude, it is possible to reach our objectives in restorative dentistry without drilling or almost without drilling. And thank you very much for your attention.